Welcome to this explainer. All right, let's just jump right in. If you're a med student stepping onto the wards for the first time, there is one skill, honestly, one absolutely crucial skill, that will define your ability to save lives during a cardiac event. And that's decoding the ultimate cornerstone of acute coronary syndrome diagnosis, the 12-lead ECG. Today, we're not just staring at a bunch of squiggly lines. We're going to treat this as a real, hands-on clinical case study to train your eyes to see exactly what the heart is trying to tell you.
So here's the game plan for today's ward round. We've got 6 key steps to get you reading these ECGs with total confidence. We'll start with ST elevation mimics, then hit the territorial rules and the reciprocal mirror. After that, we'll dive into some clinical case studies, unravel the posterior mystery, and finally, lock down ischemia versus infarction. Let's get to it.
Section 1. ST elevation mimics. Because before we start panicking and calling the cath lab for a massive heart attack, we've got to spot the imposters.
Right, so not every ST elevation means an acute infarct. You need a mental checklist to eliminate these mimics right off the bat. First up is benign early repolarization, which really shouldn't be causing chest pain anyway. Second is a left bundle branch block, or LBB, which could just be an old finding. Third, we have left ventricular hypertrophy, or an LV aneurysm, again, usually not the culprit for acute chest pain. And finally, pericarditis. Now this one does cause chest pain, but it has completely different diagnostic criteria. We literally have to cross these off our list first so we can focus purely on true acute myocardial infarctions.
Okay, moving to Section 2, the territorial rules. Once those mimics are out of the way, we rely on the #1 defining concept of an acute MI. It is strictly territorial.
I want you to picture the ECG leads like a network of security cameras set up around a building. If a specific coronary artery blocks up, its specific neighborhood, that exact territory, starts starving for oxygen. And the security cameras pointing directly at that neighborhood, those are the ones that record the distress signal. And on the printout, that signal looks like an ST elevation. It's a highly localized, purely anatomical event. This chart here brilliantly maps out our security cameras. You've got the inferior wall, mostly fed by the right coronary artery, and it's being watched by leads I, 3, and AVF. Then there's the anterior wall, supplied by the left anterior descending artery, or LAD, monitored by V1 through V4. And finally, the lateral wall, getting blood from branches of the LAD and circumflex, which is under surveillance by leads I, AVL, V5, and V6. Seriously, memorize this map. It's going to be your absolute best friend on the wards. Section 3, the reciprocal mirror. Because, honestly, territoriality is only half the story.
Remember, the heart is a three-dimensional object, right? So if one territory is actively infarcting and throwing up an ST elevation, the leads looking at the exact opposite wall of the heart are going to act like a mirror. They'll pick up that same electrical signal but in reverse, which shows up as ST depression. So practically speaking, the lateral wall sits opposite the inferior wall. Therefore, lateral reflects inferior. In the same way, the anterior wall sits directly opposite the back of the heart, meaning anterior reflects posterior. It's a perfect mirror image.
Section 4. Clinical case studies. Enough theory? Let's step up to the bedside and actually apply these golden rules to 3 distinct patients.
Okay, patient number 1. You're handed this ECG. You see really obvious ST elevations spanning from V1 all the way through V5, and if you squint a little, there's a subtle rise in lead AVL. The big question here is, do these elevations actually belong to the same anatomical territory?
Boom. Yes, they do. Leads V1 through V4 are covering the anterior territory, while V5 and AVL are catching the lateral territory. Since these areas are physically right next to each other, they merge to give us our diagnosis, an acute anterolateral myocardial infarction. Our cameras are basically showing us one massive, continuous zone of oxygen starvation.
Now, looking at another anterolateral example, I really want you to focus on the shape of these ST elevations. Notice how they have these massive, bulging, rounded tops. In the clinical world, we literally call these tombstones. It's a visceral, unmistakable cry for help from the heart muscle. When you see tombstones, there's no debate. You know for sure the infarction is incredibly severe. Let's move on to our second bedside scenario. This patient's ECG is showing ST elevations down in leads 2, 3, and AVF. But look up at leads I and AVL. There's some definite ST depression there. How are we supposed to put these two puzzle pieces together? Well, notice how perfectly this lines up with our rules. The elevation in I3 and AVF locks in an acute inferior ST elevation MI. And what sits perfectly opposite the inferior wall? The lateral wall. So those ST depressions in I and AVL, that's your textbook mirror image reciprocal change. The anatomy makes total sense here.
Section 5. The posterior mystery. Because sometimes the heart likes to throw a total curveball, and we have to step entirely outside our standard 12-lead view.
Okay, here's the mystery. Patient 3 has inferior ST elevation in 2, 3, and AVF, but they also have really deep ST depressions in the anterior leads, V1 through V4. Now wait a minute. We know the inferior wall reciprocates with the lateral wall, not the anterior wall. So if the anterior leads aren't mirroring the inferior leads, what exactly are they looking at?
What's wild here is that the anterior depression is actually a reciprocal mirror reflection of a totally hidden infarct happening on the posterior wall, literally the back of the heart. The standard 12-lead ECG simply doesn't have cameras looking directly at the back, so all we get to see is its reflection in the front.
So, how do we solve this? Easy. We physically move the cameras. We upgrade to a 15-lead ECG by taking leads V7, V8, and V9 and slapping them directly on the patient's back right under the left scapula. When you do that, bam, the hidden posterior wall ST elevations light right up. If we hadn't thought to use the 15-lead, we would have completely missed how far back this infarct extended.
And finally, Section 6, Ischemia versus Infarction. As we wrap up our analysis, we've got to draw a hard line between an actual infarction, which is localized cell death, and ischemia, which is more like generalized oxygen starvation.
The core difference really just lies in the patterns. An infarction, as we've been talking about, gives you ST elevation that is strictly territorial, almost always paired with those reciprocal mirror changes. Ischemia, on the flip side, is basically marked by widespread ST depression, or maybe newly flipped T waves that just seem to show up everywhere. It's totally non-territorial. It ignores those strict anatomical boundaries because the entire heart is collectively gasping for oxygen, rather than just one blocked-off neighborhood.
Okay, to totally wrap up our clinical rounds for today, I want you to picture this real-world scenario. A patient is sitting right in front of you. They're clutching their chest with ongoing, highly suspicious pain. But you look down at their initial 12-lead ECG and nothing. It is completely normal. What is your very next move?
You absolutely always repeat the ECG. Listen, acute coronary syndrome is not a static photograph. It's a dynamic, evolving event. A tiny clot can become a massive blockage in a matter of minutes. Vigilance, repeating the test, and just trusting your gut clinical suspicion are your best diagnostic tools. So next time you grab an ECG printout, ask yourself, are you just staring at squiggly lines, or are you actually seeing the territory? Keep learning, keep pushing yourselves, and I'll catch you on the next ward round.